Good morning, everybody. Welcome to Grand Rounds for February the 12th, 2025. I'm going to start with the land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. So 50% of the audience is made up of the presenters so far this morning. The presenters are our CHEO oncologists, and that is Drs Donna Johnston, Leslie Abbott, Jason Berman, Renee Pierre Fortin Boudreault, Brianna Empringham, Ravina Ramphal, and Nirav Thacker. And their bio is hopefully only some portion of as long as their presentation. Okay, so the CHEO division of Hematology Oncology has 10 members, 3 of whom primarily focus on hematology and 7 on oncology. Today's Grand Rounds is being presented by all the oncologists in the division in honor of International Childhood Cancer Day on February the 15th. Rather than read a biography for each presenter, instead you're getting a fun fact for each of them. So, Dr. Abbott is a former synchronized swimmer who grew up in Orleans, is the mom of 3 kids, and can lick her elbow, which you might want to ask her to demonstrate during her part of the presentation. Dr. Berman has a fancy shoe collection, some of which he's demonstrating today. Dr. Renee Pierre Fortin Boudreault has 6 children under the age of 10 and hence a very chaotic household, and also is a very good singer, which she probably thought I would say. And Dr. Brianna Empringham is also a very good singer, but has a much higher voice than Dr. Fortin Boudreault. Has 2 dogs, a cat, and a small child, and is basically running a petting zoo out of her house. Dr. Donna Johnston has taken up figure skating as an adult, does not fall down on the canal, often skates on it before work, and is taking figure skating lessons where she is working on her Fiesta Tango dance. And Dr. Ravina Ramphal has worked and trained as a physician in 4 countries on 4 different continents: South Africa, New Zealand, the United Kingdom, and Canada, although the United Kingdom is not a continent, so I should say yeah. Dr. Nirav Thacker met Prince Harry when he was training at Marsden, and rumor has it they are now besties. I don't know if that was before or after the split with the rest of the royals. And the title of their presentation is, as you can see on the slides, Childhood Cancer in 2025 and Beyond, How Far We Have Come.
Thanks, Hillary. Sorry, I don't know how to advance there. Sorry. So the objectives of our collective talk today are to review the advances, including molecular and immune therapies in childhood cancer, and to discuss next steps in childhood cancer. We're all going to talk about our disease groups and the successes that have happened or are waiting to happen. So this is in honor, as Hillary mentioned, of International Childhood Cancer Day, which is on the 15th of February every year, the day after Valentine's Day. Every year, more than 400,000 children and adolescents are diagnosed with cancer, and the rate of survival really depends on the region. 80% survival in most high-income countries, but it is as low as 20% in low and middle-income countries. And there is a WHO Global Childhood Cancer Initiative, which the goal is to eliminate all pain and suffering of children fighting cancer, and to achieve at least 60% survival for children diagnosed with cancer around the world by 2030. So in terms of statistics for cancer in Canada, childhood cancer in Canada, there's approximately 1,000 children per year in Canada diagnosed with cancer. The most common diagnosis being leukemia, followed by central nervous tumor cancers, lymphoma, and neuroblastoma. About 84%, though, of children diagnosed with cancer in Canada will survive their disease. So within Ontario, and this data is from POGO, the Pediatric Oncology Group of Ontario, there are about 400 children per year diagnosed with cancer, the most common being leukemia, followed by other solid tumors, and then CNS tumors coming in third. The incidence within Ontario is increasing by about 8% per year, and the average age of a child diagnosed with cancer in Ontario is 5 years. Their survival within Ontario has improved significantly. The 5-year survival in the 1989 to 92 range was 77%, and it increased to 84% in 2018. And if we look at by cancer type, you can see one of the biggest survival increases is in neuroblastoma, as well as in ependymoma, a type of brain tumor. And well, leukemia and lymphomas have quite a good survival, which is also improving. When you look at age group, the increase in survival has been increased across all age groups, and it's not specific for one age group. And then when we talk about children with cancer who do not survive their disease, about 50 children per year in Ontario die from their cancer, but this rate is decreasing by about 1.3% per year. And you can see that CNS tumors account for the majority of children, the most number of children who die from their cancer. It remains the #1 cause of death by disease in children. So we're going to go through each a variety of tumor types of pediatric cancer and what has happened to them, what the progress that we've made with them over the last several years. And I'm going to start with the story of high-risk neuroblastoma. So neuroblastoma is a common tumor. It's one of the most common solid tumor malignancies we see in children, accounting for about 8 to 10% of childhood cancers. It's slightly more common in boys than girls. There was a study done in Quebec actually looking at screening for neuroblastoma in infancy because there's a urine marker for neuroblastoma, but this did not show any change in mortality from neuroblastoma. So the clinical presentation is often with an asymptomatic mass, or you can have symptoms from the mass. These are this image is to show an abdominal neuroblastoma, what it looks like, and this is from a paper that we published several years ago, where the neuroblastoma cells can go to the bones around the eyes and give an appearance. It looks like black eyes or raccoon eyes, but this is what it looks like on a bone scan. So the typical therapy for neuroblastoma is with, there's initial diagnosis, there's chemotherapy, there are 5 cycles of chemotherapy, there is stem cell transplant post-chemotherapy, actually 2 transplants. There was surgery, prior to transplant. They get 2 transplants, they get radiation therapy, and then they get 5 cycles of immunotherapy. And the progress, though, for this tumor has been significant over the last several years. And the reason for this significant progress is because of a treatment called anti-GD2 antibody. This was designed in the lab of Dr. LSU, and a study was done through the Children's Oncology Group. The anti-GD2 antibody is given post radiation therapy, sort of as a mop up neuroblastoma cells. So the original study done through the Children's Oncology Group led by LSU had about 200. It started with 250 patients, but ended with 226 patients, and they were randomized to either receive anti-GD2 or not. And the GD2, GD2 is an antibody that is on. GD2 is a protein that's on neuroblastoma cells, and the antibody causes cell death of these neuroblastoma cells by different mechanisms, phagocytosis, complement lysis, and NK cell cytotoxicity. And when they did this study looking at comparison of GD2 versus patients that got antibody versus not, so the patients that got immunotherapy, there was a significant improvement in survival. And in oncology terms, survival increase, like we're really excited when it's like a 3%, 4% increase in survival. So you can see this had a 20% increase, which is really quite remarkable. So the event-free survival increased from 46 to 66%, as well as the overall survival from 75 to 86%. So this has become the standard of care to use this immune therapy, and then we've built upon that for treatment for neuroblastoma. So when patients with neuroblastoma relapse, we don't have a lot of treatment options, but they started using this GD2 antibody for patients that developed relapsed neuroblastoma, which used to be there was basically gave drug to prolong survival, but it did not allow for cure. But with adding the anti-GD2 antibody, even for patients who had already received it, there were a significant number of patients who went into complete remission with this therapy. So again, this has become our standard of care. And I'm just to highlight where we're at with the next steps for neuroblastoma therapy. So, and this is a complicated slide, but just to show that this is the new protocol for upfront for newly diagnosed high-risk neuroblastoma. And what they're doing is they're adding in this immune therapy to upfront chemotherapy prior to transplant to see if this will also improve survival for children with high-risk neuroblastoma. And this is just to highlight the next phase for the relapsed neuroblastoma. They're adding the immune therapy, which is called dinutuximab. That's the trade name for it. Adding this in with another drug called DFMO, which has been studied and shown to have some improvement in neuroblastoma. So there are steps to improve the survival of this disease. And now we're going to move on to Renee Pierre, who's going to talk about ALL.
So yes, I'm going to talk about leukemia, and as a reminder, leukemia, as Donna said, is the most frequent childhood cancer, and the two main acute leukemias that we see in children are ALL and AML, ALL being the most frequent one, and within the ALL group, we have the B-ALL, again, the most frequent one, and the T-ALL, which we see less frequently. So today, we're going to focus more on B-ALL. So ALL is truly a modern success story of medicine. It went from being universally fatal in the 50s to having now a cure rate of about 90%. That being said, in the last 15 to 20 years, we hadn't had a lot of improvement in the numbers, even though we tried to intensify regimens or try different combination, we were just not getting any results. So we had to change our strategy and try other molecules to see if we could get better results. And one of those molecules is blinatumomab, which is a type of immunotherapy. It's a bispecific T-cell engager. So what it means is that on one side, it binds to the patient's own T-cell, and on the other side, it binds to the CD19 positive blast cells. So it allows the T-cells of the patient to cause apoptosis of the leukemia cells. So it's really using the patient's own immune system to get rid of the leukemia. Blina worked very well in the relapsed and refractory setting, so the next best step was to try to bring it to frontline therapy. And this is when leukemia became more complicated than neuroblastoma. So this is a trial by the COG that was for the standard risk patients. So the standard risk patients are the patients that are diagnosed between the age of 1 and 9, and they have to have a white count of less than 50 at diagnosis. The rest of the patients are high risk. So within the standard risk population, there is some variation in outcomes. And we know there's a group that does very well called the standard risk favorable group. So this group has favorable cytogenetics and a good response to treatment. And their event-free survival rate is 98%, with an overall survival rate at 5 years that is very close to 100%. So this group were not given Blina because they do so well already. They were just given standard of care. Then you have the standard risk average group, which are the patients who have neutral cytogenetics and a good response to treatment. And then the standard high-risk group, this group has either CNS disease at diagnosis, unfavorable cytogenetics, or a less good response to induction therapy. So these two groups were randomized between standard of care and standard of care plus 2 cycles of Blina. The study started in 2021, and in June of 2024, there was a planned analysis by the Data and Safety Committee. And after reviewing the results that they had so far, they recommended to stop the study and disseminate the results. So all of a sudden, the study closed, and for about a week, we were left in the dark. We didn't know what was happening. I mean, we did have a small idea, but we didn't know for sure. And then we got a memo from the COG showing those results. So essentially, adding 2 cycles of blinatumomab to our standard of care was increasing the event-free survival rate by 10%. So the standard risk average group went from 90% to 98% event-free survival rate, and the standard high-risk group went from 85% to 94%. So basically, those two groups were having similar outcome to the most favorable groups that we had before. So with Blina, we can prevent 2 out of 3 relapses in our patients. Blina does have a couple of downsides. First, it has a very short half-life, less than 2 hours. So it has to be given over continuous infusion over 28 days. So their port is accessed for 28 days. But this is not going to last forever. They're already starting to work on longer acting and sub-Q Blina. There's a risk of cytokine release syndrome, but very low risk because when we give it, the leukemia burden is very low, so not something we have to deal with commonly. There's a risk of neurotoxicity, especially seizures in Down syndrome patients, so we have to prophylax them for that. There's also a risk of infections for some groups, but again, not something we are not used to deal with. And there is no CNS penetration, so we do need to give IT during Blina. So the future of ALL therapy, obviously we all dream of a regimen that will be chemo-free, and we will get very close to it. The next trials will try to remove all or most of the intensive parts of chemo and replace it with Blina and maybe other immunotherapy so that the chemo becomes much less toxic overall.
Okay, so I'm going to speak about infant ALL and also CAR T cells. So infants can get ALL. Infants can get ALL. And when they do, it's a different disease. So it has a significantly inferior prognosis to our children over 1 year of age. Overall, infant ALL has a prognosis of about 50%, and there are specific high-risk groups with genetic changes that have a prognosis closer to 20 to 36%. It's very aggressive, so relapses tend to happen early on in treatment, and there's no clear evidence. So there's been about 15 years of trials looking at whether or not we can intensify chemo in this group or take everybody to transplant, and nothing has really translated into improved survivals for this very high-risk group. This is also the most vulnerable group, as you could expect, to toxicity from chemotherapy because they are little babies. So they are good candidates for de-intensifying chemo or for doing alternative approaches. And so blinatumomab comes back into the picture here again because the Vanderslee group added just 1 cycle of blinatumomab, which is 28 days of pretty low toxicity immunotherapy, to infant ALL, and they found almost a 30% improvement in disease-free survival and overall survival. And so these are very impressive survival curves on this study. Focus on B and C. This is just looking at A is just looking at the current study versus historical. But this was a non-randomized study that looked at historical controls, but they used the backbone that was the same as historical controls. And so they found over a 30% improvement in disease-free survival with prognoses like we've never seen prognosis like this in infants, like 81%, 93%. Was unheard of and would not be what we would have quoted a family. And so this is no bone marrow transplant, just the integration of 1 cycle of Blina in a standard chemo backbone. And so this is now our standard of care for high-risk infants. I have no idea. We have 3 infants on active treatment right now, and I actually have no clue what to tell them about their prognosis when parents ask, because we don't have long-term data from these Blina trials. This was published in 2023, and anything they read online is going to be significantly underestimating their prognosis. So it's very, very hard to say in an immunotherapy era what the future looks for infants with ALL. The number of cycles, so, the adults give 4 cycles of Blina. We give to our over 1s 2 cycles of Blina. Infants get 1. We don't know the correct number of cycles, or the best chemotherapy backbone, or if we can de-intensify our chemotherapy, given our good outcomes with Blina. Anytime you use like a immunotherapy that targets one marker, like CD19, we always worry that there's going to be a phenotype switch in leukemia, because leukemia divides rapidly and has the ability to become resistant to treatment. And so we've always been concerned about CD19 negative relapses. Infants also can phenotype switch to AML, which is harder to treat once they phenotype switch. And so interestingly, there was no phenotype switch or CD19 negative relapse in this study, but we've actually had one at CHEO that switched to AML after blinatumomab. So we'll see. I think, the genetic landscape of relapse will change with blinatumomab. And we cannot talk about advances in ALL without talking about CAR T cells. So the commercially available CAR T cells target the same marker as blinatumomab, so CD19. CAR T cells are manufactured by collecting the patient's own T cells, manufacturing them with a chimeric receptor to target the CD19, and then infusing them back into the patient so that they target their own CD19 positive cells, including normal B cells. But B cell ALL in general is a good immune target because we can wipe out the B cells, without a lot of toxicity. We can replace immunoglobulins with IVIG, but exactly. But the long-term toxicity of wiping out your B cells, like B cell aplasia, is actually our hope post immunotherapy for CD19 positive B cell ALL. Yeah, and sees a lot of our patients now. And so CAR T cells have a co-stimulatory domain. That means that they can live in the patient's body for years. So we've seen CAR T cell persistence for up to now 8 years as the longest patient. And so the first study was done in refractory relapsed B cell ALL. Okay, which had a prognosis of almost 0 historically. These were patients that failed 3rd, 4th line therapies that were really being told this is experimental. And Philadelphia published their data in 2015 with a phase 2 trial with a 3-month remission rate of 81%, which was, again, mind-blowing. These patients would have failed multiple lines of therapy already. The average was 3. Longer-term follow-up shows probably a remission rate around 55%, and there are side effects that mirror the ones of blinatumomab. The other addition to CAR T cells is they're very expensive. So there's a significant financial burden on a government level, because right now they're covered, but only in very specific indications. And the role for a consolidative transplant is currently being explored. The next steps in terms of CAR T cells, so we don't have a nice marker like B cell ALL for AML or even T cell ALL. You can't just wipe out all the T cells or the myeloid cells. That would be bad. And so CAR T cells are being manufactured for AML and T cell ALL, but they are early on in development still. And there recently was a trial that showed promising results for anti-CD19 CAR T cell therapy in lupus. And so solid tumors are currently under investigation as well.
Thanks, Brianna. So I'm going to talk about AML, and I've been looking after AML patients for over 20 years, and sadly, we don't have the outcomes in AML that we have in ALL, and have really been treating these patients the same way for, the last 30 years. But there are some new agents on the horizon that I'm going to touch on. Again, to remind you what Renee Pierre showed you, that AML is 20% of childhood leukemia. We tend to see 2 peaks in AML, like in really young kids and babies and in teenagers. AML is really much more of an adult disease. So, and I promise I'm not going to show any schemas, because I saw Joe look very upset when the protocol schema went up. So you've been hearing a lot about immunotherapy, targeted therapies, and so gemtuzumab ozogamicin or Mylotarg, which targets CD33 on myeloid cells, on AML cells. So you've been hearing about CD19 on ALL cells. CD33 is on myeloid cells, and really in some ways was one of the first immunotherapies. And this was actually discovered in the lab of Irv Bernstein when Donna was there, around the same time when Donna was there as a postdoc, so out in Seattle. It's expressed on many AML cells, and this shows you gemtuzumab is an antibody that's linked to calciumycin, which is it's an antibiotic that's cytotoxic. You can see on graph A there that if you look at a number of AML patients, different AML patients may have different amounts of CD33 on their AML blasts. And you can see then in the graphs looking at OS, overall survival, or disease-free survival, so that's from the time that they're in remission, the more CD33 expression they have, the worse they do. So their outcomes are worse. But the good thing about that is we can actually target that CD33. So using gemtuzumab ozogamicin or GO, you can see from this study that Jess Pollard published in JCO in 2016, that in those patients that actually have higher levels, so the quartile 4 higher levels of CD33, if you look at event-free survival in graph B, you can see actually there's a statistically significant improvement in survival, whereas there really isn't in those on graph A that have lower levels. And then you can see as you go into on the graph that's on the right side, if you look at different risk levels of AML, so AML can be classified into low risk, intermediate risk, and high risk. Within all those groups, if you have high levels of CD33 expression, you can see that there's improvements when you add gemtuzumab ozogamicin. You can see that yellow line in B, D, and F is higher. So what are some high-risk features in AML? I mentioned the high-risk AML. These are the patients that do worse. So one is what used to be called an MLL rearrangement, now called KMT2A, because it's actually a lysine. K is lysine methyltransferase. That's actually what happens, and so that's why it's been named. This is actually common in infant ALL, so Brianna had this on her slide, but can be common in high-risk AML. And when you get KMT2A, it has a number of different rearrangement partners. So you can see there it can rearrange with those various different genes, FF1, MLLT3, et cetera, and causes these fusions. And you can see there in normal hematopoiesis, it functions as adds a methyl group to the lysine of the histones, and that impacts what genes are going to be expressed or not expressed. And that when you have a rearrangement, it changes that. And so you end up with this very sort of primitive program where you express genes like HOXA and MEIS, which actually makes your cells much more stem-like and more aggressive. So that's one rearrangement. The other rearrangement is something called FLT3, which stands for FMS-like tyrosine kinase. So that's the cell membrane. That's the FMS3, the FLT3. And it's got a number of different regions, including that region called the juxtamembrane domain. And you can get these ITD mutations, which are internal tandem duplications, where you get these duplicated regions that can occur in that protein. Both of these tend to occur independently and can confer high risk. So we looked in this population whether gemtuzumab ozogamicin could improve outcome, and you can see on the left actually that in KMT2A rearranged AML that the addition of gemtuzumab made an improvement. So on the left you have event-free survival, so there, the higher the curve is, better. And so you can see normally when you have KMT2A rearranged, I have to stand here, right? When you have KMT2A rearranged, you have really poor outcomes. But if you add gemtuzumab, you can raise it up into the category where you don't have rearranged. And then here, this is relapse risk. So here, of course, you want to see the lower numbers better. And again, if you just have KMT2A without gemtuzumab, the outcomes are worse in terms of relapse risk, and you can improve that by adding gemtuzumab. And separately in the FLT3 patients in a different study, you can see here that if you add gemtuzumab, you have a improvement here in relapse risk. It didn't really improve disease-free survival. So this isn't going to be the answer for FLT3 ITD AML, but you can add a drug that specifically targets this FLT3. And so if you look back here on this slide, you can Okay, you can see that there you can actually inhibit FLT3 with a specific targeted therapy. And when you add here sorafenib, which is a FLT3 inhibitor, again here you can see improvements in these patients that have FLT3 ITD AML, that adding sorafenib to chemotherapy that specifically targets improves the overall survival, the event-free survival, the disease-free survival, and reduces relapse risk. And so now gemtuzumab ozogomycin, Mylotarg, and FLT3 inhibitors for those patients that are FLT3 positive AML are now part of standard therapy. I'll move on to bone tumors.
Hi, everyone. So I'm going to talk about bone tumors, and this is still a work in progress. So there are two types of bone tumors, Ewing sarcoma and osteosarcoma. Localized Ewing sarcoma has an event-free survival of about 76% and an overall survival of about 91% at 4 years, which is pretty good. Event-free survival is recurrence-free survival. Overall survival is you could still have the disease, but you are still alive. For localized osteosarcoma, the overall survival is approximately 70%, maybe a little bit lower than that. For metastatic sarcomas, however, the prognosis is not great. Ewing sarcoma has an overall survival of less than 30%, and metastatic osteosarcoma as well, and metastatic osteosarcoma is worse than metastatic Ewing sarcoma. I love this study. This was our most recent breakthrough, and this was in 2012, and I love the study for its simplicity. All they did was they took our routine chemotherapy, and instead of giving it every 3 weeks, they gave it every 2 weeks. And there was a difference in survival that was very significant. So the event-free survival went to 76% from 65%, and the overall survival went from 91%, was 91% versus 85% before at 4 years. So the bottom line is, don't delay giving chemotherapy if you can help it, because it costs lives. Osteosarcoma, the last breakthrough was actually in the 1970s with the introduction of methotrexate in the mid-70s, and after that, in the late 1970s, the introduction of cisplatin, one of the platinum agents. So it doesn't sound great for metastatic sarcomas, but blinatumomab was not created in a vacuum. It took decades of research before we got to that point. And what I want to talk to you about is what's going on that is pretty exciting. I'm going to talk about international collaboration, tumor genetics, maintenance phases of treatment, tyrosine kinase inhibitors, tumor microenvironment, and identifying early resistant cells in the blood, all in about, I think, 3 minutes. So the key here is we don't have as many patients as leukemia, thankfully. But that means that we have to collaborate with others. And the people we collaborate with are other regions in the world and our adult colleagues, because this is a disease of adolescent and young adult patients. And over the last 2 decades, I think we've done a much better job of standardizing protocols so that we can compare, and it's not apples to oranges, and even using some of the same protocols. And hopefully this is going to continue over time. And one of the examples is the Children's Oncology Group and Ewings that have collaborated quite well. Ewing sarcoma has a very specific type of genetic abnormality, the EWSR1 gene, which is a translocation on chromosome 22. And this cell is different from any other cell in your body. And it's kind of like waving its hand saying, look, I'm different. All we need to do is to figure out how to target only those different cells. And that's where the challenge is. And there's been a lot of work done. So far, it's still a work in progress, but our understanding of the genetics has improved significantly over the last few decades. Osteosarcoma is even more tricky than Ewing sarcoma because there's not one single genetic abnormality. It has a lot of genetic heterogeneity. So the underlying genomic alterations still remain largely unknown. So one patient with osteosarcoma can have a very different tumor genetically to another. And so targeting this has been difficult. However, we now have next generation sequencing, which is a method of analyzing genetic material that allows for rapid sequencing of large amounts of DNA and RNA. So each patient's tumor can be analyzed, and we look then to see if for those genetic abnormalities in that particular patient's tumor, are there any agents available that can be used? In terms of the next strategy, maintenance chemotherapy has been used in leukemia forever. And basically, you give 6 months of intensive chemotherapy for ALL, and then a maintenance phase for 2 years. The European collaborative trials are now trying to do this with sarcomas, and this we will see. We will see whether adding in a maintenance phase with vinorelbine and cyclophosphamide makes a difference after we've given our standard chemotherapy. Tyrosine kinase inhibitors are drugs that block the action of tyrosine kinases, which are enzymes that help cells to grow and divide. And they're currently used in relapse and metastatic settings to delay the progression of disease. On their own, they're not enough to be a cure, unfortunately. But if we give it to patients who are heavily pretreated, we're getting about a 10 to 26% objective response and median progression-free survivals of about 3 to 5 months, which is the same as using salvage chemotherapy in this palliative setting. However, the big difference is these are oral chemos, and they can therefore be given at home, and patients can have good quality life for that period of time. And I have 2 more slides. The second last slide is tumor microenvironment. So these tumors have to go from the bone through the bloodstream into the lungs and settle there and proliferate. And the thing that helps them proliferate in certain parts of the body and not others is the fact that there's a nurturing environment for them. So think of these environments as enablers. And if we can create a hostile environment so that these cells don't replicate far away, then we would have a significant impact, because the metastatic disease is the one that we cannot treat. And my very last slide is identifying early and resistant cells, where you have circulating tumor cells that are detectable. You can pick up the DNA and RNA of these cells in the bloodstream. So during surveillance, if we can use this to identify these tumor cells really early on and start to treat really early on, our chances of survival would be higher. Thank you.
Okay, thank you, Ravina, and good morning, everyone. So with that, we'll move on to brain tumors. So neuro-oncology has come a long way since the time of Bailey and Cushing, when they first described medulloblastoma in 1926. Molecular advances over the last 2 decades have completely transformed the diagnostic as well as the therapeutic landscape of pediatric brain tumors. So let's try and break it down. So before molecular profiling, the diagnosis of pediatric brain tumor was like watching black and white TV, right? You knew that, you could grossly make out what's going on, but essentially you were missing out on all the details. And what's happened since molecular profiling that started with medulloblastoma is that it's given a 4K ultra HD sort of clarity to the biology. And it has helped us not only subgroup all the tumors better, but also risk stratify them better, and also help us identify new entities which we actually did not know existed. And the best part is this was not just limited to bench. We actually could translate a lot of this to bedside and make changes to treatment. And the best example of that is actually low-grade glioma. So the identification of BRAF and MAP kinase activating mutations by 2 groups simultaneously in 2008 completely transformed how we were looking at low-grade gliomas. This was the watershed moment. And this actually heralded the onset of a target therapy revolution in brain tumors. So conventionally, low-grade gliomas, our aim of treatment was to stabilize the tumor. So the first thing we would tell families when we start treatment is that, the tumor is going to remain stable, and that's a win. Response is a bonus. But what happened with this targeted therapies was completely unprecedented with the waterfall plots, as you can see, across BRAF and MEK inhibitors, and actually the newer pan-RAF inhibitors as well, which is the lowermost waterfall plot, at least a different sort of plot, right? Seeing then all the curves that we have. And this sort of responses we have never seen historically, and this was a complete breakthrough. And the holy grail of clinical trials where a randomized phase 2 study showed that targeted therapies were 4x better in terms of response and 3x better in terms of their progression-free survival. And this sort of, had sealed the deal by that time. So what hasn't happened in centuries happened in this decade and within a span of 1 year. So 3 new pediatric agents got approval for pediatric low-grade gliomas by US FDA based on only early phase studies, one of which was a randomized phase 2, but based on early phase studies. So this is like, a great era to be in. And just to see, this is the patient at CHEO, right, of how actually things have changed. This was the first patient actually at CHEO who got MEK inhibitor therapy. So progressed on 2 lines of chemo, and you can see the amazing response on MEK inhibitor. Similarly, these are other patients who have had some amazing responses on MEK inhibitor, BRAF inhibitor, and now we are moving at seeing can we actually combine chemo and MEK inhibitors and see the response for the last patient on this as well. So moving on to high-grade gliomas, which actually are, pretty aggressive tumors, and unfortunately their median survival is between 12 to 15 months. But here, actually the story is even more promising. A subset of high-grade gliomas with mismatch repair deficiency actually have hypermutations, but do very poorly because of that. And their median survival at recurrence is almost 3 to 4 months. But if you see this paper from Toronto group, which is a retrospective data, shows that with immunotherapy, they actually improved the survival in these patients at 3 years at recurrence to 80%, which all of them used to die. And similar things we are seeing in clinic as well. This is a patient who had recurred and on recurrence got immunotherapy, and at 1 year out, this was the response. So forget responses in the patient. We were actually seeing that they were dying in 3 months at recurrence. And now we are having a 3-year progression survival of 80%. This is another drug for diffuse midline gliomas, which are actually one of the worst outcomes. All the patients, unfortunately die within a year. And at least we have a drug which now we feel is going to target them. And as you can see, that it not only had a radiological improvement, but also clinical improvement in this patient. At CHEO, we are just not watching the future unfold. We are actually building it and taking it globally. So you can see the spectrum of clinical trials now that we have at CHEO, and we are actually leading 2 of these international trials across the globe, and we are also not charging any tariffs for this. And you can see the spectrum, right? It's all immunotherapy and targeted therapy based. So finally, just to see, how things have changed. So historically, it was one size fits all approach because you only had 3 options to provide to the patient. And today, we are actually treating tumors based on not what they look like, but what their biology is. And this is an era of, smarter therapeutics where we are completely refining therapy of how we are treating these patients and also giving them real hope. So I think it's fair to say that in last 10 years, neuro-oncology has actually got transformed to brainy oncology now. And the best part is we are just getting started. So with that, we'll move on to the next.
Okay, everyone's still with me?
We want to see you like you're all.
Okay. Did everyone see that at home? Okay. So this is a super tough, you did see it, right? This is a super tough act to follow. I'm going to present probably something happy and then maybe something we need a little bit more work on. So my clinical practice is quite variable. People, their eyes kind of bug out when they hear about the various things that I have my hands in. But a disease type I'm very passionate about, and I have the opportunity to treat our patients with Hodgkin's lymphoma. And one of the reasons I'm passionate about this disease type is that it affects primarily adolescents and young adults. So we refer to them as AYAs, typically defined as 15 to 29, now in the modern era up to 39. And we know that particular group of patients actually doesn't do as well as younger patients or older patients. And there's a number of reasons for that. I think the initial thought was it was maybe a complacent teenager who wasn't giving us all the information, but actually we're not doing the best job of treating our teens. However, Hodgkin's lymphoma is unprecedented in terms of outcomes. So it starts with an abnormal B cell. We know of it as the Reed-Sternberg cell. You can see it up there in the corner looking like fried eggs. Primarily, again, affects adolescents and young adults. The presentation is usually painless, swollen lymph nodes, and I have a picture there. And then we talk about systemic features or constitutional symptoms or B symptoms. So we talk about fevers without a source, really drenching night sweats where you have to change your bedclothes every night, and weight loss that's greater than 10% from baseline in the previous 6 months without an effort for weight loss. Also, these patients can be intensely fatigued, as well as pruritus. I actually recently had a patient with super intense pruritus, and after her first cycle, it was like miraculous. It all went away. So the mainstay of therapy in Hodgkin's lymphoma for years and years and years has been radiation. And it was radiation from here to here, everywhere. Everybody survived their Hodgkin's. Everybody passed away of a secondary side effect from the radiation. So what has happened is a balance is tipping to try and bring in more chemotherapy and reduce the amount of radiation in the vein of having survivors who truly survive. So this Hodgkin's lymphoma is also a good news story in terms of novel therapies. So we're increasingly trying to find groups of patients who can only get chemo and not radiation. We are a little bit further behind on the pediatric side than on the adult side in the sort of 20 to 30-year-old range in terms of that. But what I always say to my dear amazing fellows, if pediatric oncology makes the New England Journal of Medicine, you better know it. And I think we're getting a very skewed view today because I think we've all shown a New England Journal publication, but it's actually super rare in P&C lung to have that. So the first one I want to show you is the brentuximab one. That would be on your right. So this was a study done through the Children's Oncology Group for high-risk Hodgkin's lymphoma, and they added in a novel agent, which is an anti-CD30 antibody attached to a molecule of chemo called MMAE. And MMAE works like one of our most common chemotherapy agents, vincristine. So it's a neurotubular inhibitor. But what happens, because it's attached to an antibody, is that it's targeted directly to the Hodgkin cell, and then that chemotherapy agent gets directly into the cell. So this showed such good survival that it made New England Journal. We're talking 95+%. But the problem with this particular study is that all the patients were still getting radiation. So another group at somewhat of the same time was asking another question, which was, can we get rid of radiation and add in another immune therapy called nivolumab to a backbone of chemotherapy? So that's the other study I'm showing. And nivolumab is a PD-1 inhibitor, so that's a programmed cell death inhibitor. So essentially what happens in this first picture here that you can see is that a tumor cell and a T cell will attach at the PD-1 ligand, and that will actually inhibit the T cell from working. So what a PD-1 inhibitor does is that it comes in and it attaches to that PD-1 antigen on the tumor cell and prevents the two from locking together. So then the T cell, through its T cell receptor, can actually work on the cancer cell. And you know what? It was so good. Again, it made New England Journal. So the next disease I want to talk about is rhabdomyosarcoma. So this is a soft tissue and muscle cancer, primarily in younger children, think toddler, school age, but really it spans the gamut. And there are two major types, embryonal and alveolar. Alveolar is traditionally defined by one of two translocations. However, we've been learning more that there's a type of alveolar without translocation that seems to have a better prognosis. The treatment for this is systemic chemotherapy and local control with radiation and or surgery, and it's quite intense therapy. So this is our most recent trial in North America, again through the Children's Oncology Group, ARST 1431, and it was our more traditional backbone of chemotherapy with a novel agent added in, temsirolimus, which is an mTOR inhibitor. I know many of you use mTOR inhibitors in various ways in your practice, but this showed preclinical data and then showed good data in the early phase clinical trial for relapse rhabdo, so it was brought forward. So you can see from the survival curves that temsirolimus didn't make a difference. So Leslie, why would you show that today? Because it's still a high impact paper, because they still show that they can do this. It's still, from what you saw from Dr. Ramphal, what she presented, it's rare in the sarcoma landscape that we bring a novel agent in, and there was so much compelling data that we did it. And in some of the commentary on this publication is that perhaps we didn't choose our patients well enough to match what was seen in the lab and what was seen in the early phase data. And then what was also done in this study was the addition of maintenance. So all patients got maintenance therapy. It was not a randomization, and we showed that that's feasible and that's possible as well. So what's next in rhabdo? That's a long story, but in my opinion, it should be more novel agents. So where do we go from here? So we've presented our New England Journal randomized phase 3 clinical trials. But how do we get there? We have to start earlier. So we need to start with early phase trials, which really traditionally we think of as first use in human, or in peds, it's first use in children. And then we have to start even before that. So how do we identify agents that we can put into early phase clinical trials? So I wanted to talk about a few cool things that are going on at CHEO. So one is something called TILs, tumor infiltrating lymphocytes. So we talked a lot about super cool CAR T cells. But TILs would be in that vein of trying to use T cells, like CAR T cells, but we're not engineering them. They actually come prepackaged. So what that looks like is that we get a sample of fresh tumor, and there's already T cells in that tumor that are probably not functioning optimally, but are already targeted to specific antigens within the tumor. So could we isolate those T cells from the tumor and then expand them, and then potentially put those T cells back into the patient to get rid of the cancer? So we were actually just awarded an innovation grant for this with the amazing RI scientist, Dr. Sean Thank you. And Dr. Eric Lacasse, where we're going to take fresh tumor samples and look to see if we can expand them in the lab. And this is already a proven technology in the melanoma landscape. So what else can we do? So CHEO has been involved since the inception of the Profile Project, which is a national pan-Canadian project for precision oncology in young people. And what this project is trying to look at is difficult, hard-to-treat cancers, taking a sample and doing molecular profiling on that, and then trying to integrate that data. So initially at the inception, it was thought, well, maybe we can find a target, and then maybe there's a drug, and then maybe we can use it. But now how it's evolved is more banks of information. So can we say, as an example, we've noticed particular hits in rhabdo patients that are hard to treat. Is there something we could target in a clinical trial? Is there a drug available? So that's really the goal about bringing more therapy and what we can do with that information. And then we've successfully sequenced, I think, over 30 patients now at CHEO, and we've done that through local fundraising. So the Phoebe Rose Rocks Foundation has been integral to that, and they now work alongside with the Kindred Foundation. So then what can we learn about patients who are on early phase clinical trials? That sounds kind of awful, but maybe it's not as bad as we think. So I'm the principal investigator on a national study where we're looking at the impact of the quality of life of patients who are on an early phase clinical trial versus those at a similar point who are not on an early phase clinical trial. And we're using standardized measures to look at that with the PEDS QL and the SPEEDY. So we're open at 11 sites coast to coast. We currently have 81 patients with a goal of 92. And thus far, what we've been able to show is that being on an early phase clinical trial does not seem to adversely affect your quality of life. So how is that helpful? That's helpful for a patient and family making a decision to go on an early phase clinical trial or not. That's helpful to a clinician in doing the consenting and how they present that to the family. So this work has been generously supported through the C17, the Kindred Foundation, and the CHEO Research Institute. So, in conclusion, I hope we've shown you tremendous gains. I hope we've shown you that we don't plan on just resting in the success that we're in, but that we have to continually do more to keep those amazing numbers that Dr. Johnston presented in the beginning. And more early phase clinical trials are really warranted to continue this success. And then my last line is that oncology is really the epitome of the multidisciplinary team. So this is a small fraction of the team. Please note, I'm not in the picture. But like I look out here and it's amazing to see, people on our team. It's the epitome of a multidisciplinary team where everybody has a job to do and everyone brings something to the patient and the family. So that's it. Thank you so much. Time for question. Should we all come up?
Yes, maybe, or maybe we'll, if there are questions, maybe questions could be directed to each of you individually, guys. Thank you so much, guys. That was a whirlwind trip through the world of oncology. And yeah, for those of us who are old, I think back to when I was in medical school and kind of the survivals then in pediatric cancers, and I'm completely blown away by all of the changes. And really excellent to hear all of the great work that's being done here at CHEO.
Hillary, when I was in grade 1, it was...
Yeah. I remember, Joe. Yeah. The other big take home is that 39 is the new 29. So that's important. All right, let's see if we have questions. We have a question. First of all, any questions from the audience here? Anne.
So much for power. You talked a lot about characterizing the tumors, like the molecular and the targeted precision medicine and all that. But if you take a step back and think of the whole patient, so I'm a bit biased. I think everybody has an immune deficiency if they develop, an infection or a cancer. But how often do you do like kind of screening for an inborn error of immunity in your malignant patients? Because that's definitely a lot of patients can present with malignancy as their first presentation of something broader.
Just before you answer, Leslie, just for the audience, the online audience, Anne. So what you're asking is how often do we screen for an immune disorder? Okay. And Leslie, if you want to stand front.
Sure. So what I heard, Anne, is that you want to consult. I don't want to speak for the entire group, but yeah, in the lymphoma space, I would say that we do a small workup. So we look at the immune globulins, we examine the CBC, we look at the inflammatory markers, and then I let the pathology guide me somewhat in that as well. And then we have started more recently where many of our patients, if not all of them, or 90% of them, get a consultation in cancer genetics as well, to have Dr. Sawyer's input on that too. I don't do anything routinely for my solid tumor patients. Similar. And I should say, correct me if I'm wrong, but before we give blinatumomab, we also examine the B cell function. So, yeah. And before we give Ritux as well, we would do that.
We do some baseline immune studies for leukemia before we give them high-dose chemotherapy and ruin their immune system. And we obviously do a history. I had one patient that had like a history suggestive. I think you saw them. They had ITP for a year before their Hodgkin's, but and with our leukemia patients, they're the one tumor group that is not routinely seen by cancer genetics. So we make sure that we have like a pretty good history about
Okay, we have a question from Dr. Czar. Go ahead, Dr. Czar.
Oh, thank you so much. I very much enjoyed your presentation. I'm a general pediatrician who works. Can you all hear me? Yeah.
Yes, we can.
Okay, good.
Yeah.
I'm a general pediatrician who works part-time in the emergency department. And I still get a little, PTSD when I think about my very first rotation at Texas Children's Hospital, which was HEMONC, on the HEMONC floor, which at that time was the 6th floor. I have just a quick question about the POGs. The pediatric oncology groups, is this like an international situation now? Because I think back when it first started, it was more like US and Canada. Could you talk about that just a little bit? I'm so curious as to how it might be relevant to, other international efforts. And then if the answer is yes, I saw you shaking your head. How does the funding stream work so that there can be this international collaboration? If you could just maybe a few moments on that.
Sure. Well, I'll start, but Dr. Johnston is our local principal investigator for Children's Oncology Group. So back, I think the early 2000s, CCG and POG amalgamated to create COG, so Children's Oncology Group, which is a cooperative group, not-for-profit group, American, I would say American-based, but almost all of the Canadian institutions, if not all of them, are a part of it. It's also in Australia and New Zealand, and I think parts of Europe as well. We regularly attend the meetings. We regularly open the studies. We have 240 institutions internationally. And then I believe we get some funding coming in for CRAs, but we also get funding for enrollments as well, so that we can continue anything. And the Pediatric Oncology Group of Ontario, Donna, who is about to become the medical director of, they also provide funding for that because of how key and important it is. So that's, my last comment about the epitome of the team is that oncology is highly collaborative. I mean, it's not perfect, but it's highly collaborative. And a long time ago, a group of oncologists or people who are treating people with cancer said, this is rare. I'm going to learn more together. And that principle really remains. So
yeah, thank you. I just don't see that in many other fields outside of medicine even. So really, bravo. Wonderful. Thank you.
Comment from Nirav, I think. Yeah.
What historically it has been is that most of the groups have been focusing on.
I don't know if they can hear you.
Yeah, you have to come up here.
Sorry, just to add, most of the groups, actually it was born out of necessity, but most of the groups actually are focusing on, the high income countries, right, which actually represent only 20% of the population of global oncology. And it is only now recently, at least PSYOP has involved more and more, which is the European group equivalent, actually. I would say non-North American group equivalent of COG, which includes more and more LMIC as well, and Donna hosted that in Ottawa 2 years ago. So I think what we need to understand as a bigger community is that we need to have more participation and involvement with where 80% of this burden lies if we truly want to make that difference and have an impact globally. So just to add on to that.
Thank you.
All right, it's 9:32, folks. So, Dr. Kavesi, I do see that you have questions there. Brianna will quickly answer. So the question is, 2 questions actually. If the CAR T cells can last up to 8 years, does this mean the patients cannot have B cells for 8 years? And if CAR T cells target CD19 and T cell ALL, Dr. Kavesi thought CD19 was a B cell marker.
Yeah, so correct that you can get B-cell aplasia for up to 8 years. They would be on chronic IVIG replacement. And then the second question, so CAR T cells, the government approved ones target CD19, but CAR T cells can be manufactured to have different targets. So for T cell ALL, we wouldn't target CD19 because it wouldn't be the right target. We would have to do a T cell specific target, which has been the challenge to target T cell ALL without targeting all your T cells and giving you basically a severe immunodeficiency. And so CAR T cells don't always target CD19. Only the commercially available ones do right now, and those are only for B cell ALL. They need alternative targets for different diseases.
All right. Thank you very much, folks. Everybody remember your evaluations. And enjoy the rest of your day. Thanks, guys.